Hey friends, it's Masood. Welcome back to Med School Moose. This video is going to be the start of a new series called EKG Spotlight. If you're brand new to my channel, welcome. My name is Masood Mohammed. I create a ton of high-yield content for medical students and residents, including things like USMLE and complex prep, but I am also a practicing emergency medicine physician, which is part of why I wanted to make this video. These EKG Spotlight videos will focus on some interesting cases, patients that I've taken care of, as well as interesting EKGs. As a disclaimer, this is not any formal medical advice or anything like that. This is purely educational, and I am not an EKG expert. As an emergency medicine doctor, I look at a ton of EKGs, but I am by no means an expert. I just think this will be some really awesome cases and really awesome learning. Be sure to subscribe to my channel to receive all of my latest content. Be sure to check out my website, medschoolmoose.com. I will link that in the description below. That being said, let's go ahead and jump right into it. So the case is going to be a 76-year-old male who presented to the ED for weakness and syncope. The report that I got from EMS is that the family found him minimally responsive in the bathroom and they called 911. His past medical history is coronary artery disease. He does have prior stenting, as well as hypertension and diabetes. The report that I got is that EMS was initially going to call a stroke alert because the patient was weak and kind of altered, but they ended up calling him in as a STEMI because his EKG was concerning. And EMS also said that the patient was becoming tachycardic, reportedly to the 260s en route, and there was concern for SVT, but this resolved spontaneously before the patient even got to the ED. So on arrival here, the patient's vital signs, he's hemodynamically stable, a little bit tachypnic, but really nothing too out of the ordinary, satting 100% on room air. Physical exam, I'll tell you, for the most part, was pretty unremarkable. He was a little bit somnolent, but he was arousable. He was protecting his airway, no gross neurologic deficits. He was moving all of his extremities spontaneously. So those of you that are medical students on an EM rotation, or those of you that are EM residents or even EM docs, this is bread and butter for emergency medicine, right? It's a patient that comes in with vague complaints like weakness, we get limited history, and we kind of have to do that kitchen sink workup to try to figure out what's going on. And of course, part of that workup is going to be an EKG, which is what I did, and here's the EKG. Now, I'm not going to go through the entire thing. I do definitely recommend having an algorithmic approach when you're looking at EKG, so, rate, rhythm, axis, signs of ischemia, intervals, morphology, that kind of thing. But these videos aren't going to be about that. We're not going to get crazy detailed. I will tell you the machine read was atrial fibrillation at about 84 BPM. The machine was saying there's aberrant conduction or premature ventricular complexes, a right bundle branch block, kind of looking at V1, you can maybe appreciate that. And then also a possible acute inferior MI and an anterolateral MI. So a lot of different things that the computer was kind of throwing at me. Me looking at this just at an initial glance, the things that I'm noticing is that this is a wide complex and kind of irregular rhythm. So when you kind of put all those things together, a wide complex, a regular rhythm, you have a patient that's kind of altered, weakness, syncope, the main thing that came to me was hyperkalemia. So the initial things that I did were I started treating this patient with calcium gluconate and sodium bicarbonate. These are some of the initial mainstays of treatment for hyperkalemia. I did not initiate other medications like insulin and dextrose or albuterol or anything like that because I didn't have any workup back yet. I was just initiating those things primarily to stabilize the cardiac myocytes and to kind of see if I can shorten that QRS since it was such a wide rhythm. As I did my workup, though, the patient's blood work actually came back. He was hyponatremic to 121, hypokalemic to 1.7, and the troponin was slightly elevated to 0.17. This is the regular troponin, not the high sensitivity troponin. My initial blood work, the patient was hypokalemic to 2.3, and I was kind of confused by that, so I actually ended up repeating it. And as you can see here, that potassium level was even lower, 1.7, so extreme hypokalemia. I'm not going to get too much into the details, but the clinical course is that I consulted cardiology. They recommended initiating the patient on a heparin drip due to concerns for NSTEMI with that EKG and the elevated troponin, as well as electrolyte repletion. I actually ended up signing this patient out to one of my colleagues, and the rest of the workup happened. We got some CT imaging because the patient was reportedly found down in the bathroom. He was a little bit altered, and the CT of the head showed an intraparenchymal hemorrhage. It was actually a multi-compartmental intracranial hemorrhage. There was no midline shift or anything like that. The patient actually had to get his heparin reversed with Kcentra because of the issue with bleeding. He had a prolonged hospital course, waxing and waning mental status throughout his course, but he actually ended up getting an AICD for ischemic cardiomyopathy, and at the very end of all this was ultimately diagnosed with amyloid cardiomyopathy. So again, a really interesting case, really severe hypokalemia causing a weird, irregular, wide complex rhythm. That's not something that I've really seen frequently. Guys, thank you so much for watching. If you enjoyed this video, definitely leave me a like and drop me a comment, and I'll definitely be making more of these if there is interest. Click here on the left to watch part 1 of my emergency medicine high-yield facts videos, which are awesome for EM residents or recent grads, and click here on the right for another video that YouTube thinks you'll love. Be sure to subscribe. Thank you for watching, and I will catch you in the next one.